Last week, for those of you who joined, we spent some time talking really about kind of the epidemiology of hepatitis B globally and nationally. And we also talked about how to model our conversations around screening. And today what we're going to do is actually, it's going to be within this 5-part series, really a 2-part on serologies. So we're going to talk about what the hepatitis B serologies tests are and how do we interpret those test results when we put them together. And I think we decided to spend 2 sessions on this because I think this ends up becoming a barrier for a lot of providers in terms of adopting more active Hep B screening, particularly for those of you who are on the kind of front lines of screening measures, particularly primary care physicians, and interpretation of these serologies has been confusing, and the terminologies we've used historically have not been very helpful and descriptive, so we're going to spend a little bit of time talking about this. So this is going to be part 1. Next week we'll go through kind of part 2. We're going to start with our case study. So we have, this is building upon our patient from last week, our 28-year-old woman who was born in the United States. Her parents emigrated from Taiwan 2 years before she was born here. Parents were born back home. Patient met with her primary care doctor, as you'll recall, to discuss family planning. She initially resisted Hep B screening. She ultimately agreed to move forward with undergoing Hep B screening after the physician explained the consequences of untreated infection and the basis for CDC screening recommendations. So I'll start just here. What tests do you order for a patient when you're screening them for hepatitis B? And I would love to open this part up before we launch into the rest of the presentation for input from all of you. So what tests, when we talk about screening or first-line testing for hepatitis B, what tests come to mind? And feel free to use the chat function as well.
Hepatitis B surface antigen, hepatitis B surface antibody, and then I usually check a hepatitis B cord total.
Great, and was that Taryn?
Yes.
Okay, thanks so much. Absolutely. So those are the tests we're typically talking about when we're talking about screening. So again, just to recap, Hep B surface antigen, which we abbreviate HB AG, really stands for hepatitis B surface antigen. It's a marker of active infection. Certainly if you only had one test out of all 3 of these that we're going to talk about, this is really the most important test in that it's really the marker for active infection. By definition, in order to define somebody as having chronic hepatitis B, that surface antigen needs to be positive for at least 6 months. Now, a lot of times from a clinical standpoint, aren't necessarily repeating surface antigens, with the exception of if you think that this person might have more recently acquired the infection or have acute infection. And remember last week we talked a lot about kind of the age at which you acquire this infection really influences your risk for going on to develop chronic infection. Now, worldwide, more than 50% of Hep B cases are transmitted from mother to child at the time, most commonly at the time of birth. And therefore, because of the maturity of the immune system and the ability of this virus in immunity systems that are not very well developed to integrate into host genome, we know that most people who acquire this as newborns or at the time of birth or even in early childhood go on to develop chronic Hep B infection, the vast majority, 90+%. That's very different than if you acquire this infection, right, as an adult, and barring any other immunological, suppressive factors. And in adults who acquire this infection, they typically most commonly can kick this virus out of your system and have higher rates of Hep B clearance, so much lower rates of chronic infection if you if you acquire this as an adult for most people. So again, keeping in mind the right clinical scenario, the patient that you're actually dealing with, you know, can kind of give you clues about whether or not you're suspecting more recent infection versus, you know, somebody, particularly people who originate from countries where this virus is more endemic, whether they're probably more likely to have, you know, acquired this potentially as a newborn at the time of birth or early childhood. So that's Hep B surface antigen. The next test when we're talking about screening or testing for Hep B is the hepatitis B surface antibody. Now, this is a marker of immunity to hepatitis B infection. And so while this also is a very important test because it can tell us who's immune and we don't have to worry kind of about acquiring Hep B infection, what it doesn't distinguish for us is who is immune due to vaccine, somebody who's been appropriately vaccinated and developed immunity, so they never really truly had infection with hepatitis B, versus somebody who did have infection with hepatitis B. The most common scenario that I just mentioned was like an adult who gets this, maybe from unprotected sexual intercourse, and they go on to develop immunity and they kick surface antigen out of their system as they're clearing this virus and develop surface antibody. So the surface antibody alone doesn't tell us if you're immune from previously having had this infection versus being vaccinated to hepatitis B. This is going to probably be most important, particularly as we talk about some of the topics we're going to cover in the 5th module in this 5-part series, particularly with risk to reactivation. The third test we really often typically talk about is this hepatitis B core antibody test. This is an IgG total antibody test, and it is commonly used as part of screening. And this can help distinguish in some patients who's really been infected before and has immunity versus some other kind of less common interpretations of this test. And we're going to go into more details about what those more common other interpretations of the test can be, including false positivity of the test. And then finally, the last thing we'll talk about with respect to acute Hep B with Hep B screening is this concept of acute Hep B infection. So certainly if you come in with, and a patient comes in and they see you and there's any suspicion that this could be acute Hep B infection, you know, other sexually transmitted infections, recent risk factors for acquiring hepatitis B infection, you know, viral prodrome coupled with maybe alterations in their liver test and or overt jaundice. Those might be things that kind of clue you in that you might be dealing with an acute Hep B infection. And in those cases, you want to make sure that you are checking a hepatitis B core IgM antibody test. And if that's positive, that's diagnostic for acute hepatitis B infection. So again, in the right scenario where you're really suspecting very recent infection, this could be really helpful test to check. Okay, so it's hepatitis B serology. It's really a two-step process. So we start with the screening test that I just mentioned on the other, the last slide. And then that's in anybody who tests surface antigen positive, again, which is a marker for active infection and usually, you know, coincides with chronic infection for most of the populations, particularly foreign-born populations that you're seeing. Then if that surface antigen is positive, it should lead for you to obviously counsel patients on their test results, but then in terms of a testing workup, it should lead you to check some additional serologies. And those additional serologies will include hepatitis B E antigen test. And this can be a surrogate marker of a high viral load, which I'm going to talk about. I think one thing that often gets us a little bit caught up in how to interpret these test results are some of the terminologies that we use for quote unquote these different phases of hepatitis B infection. Typically people in an earlier stage of this infection will be E antigen positive, and then on a timeline for most people of around 10 to 20 years, you go on to lose E antigen and develop E antibody, which is the second test. So anti-HBe here stands for really your antibody to E antigen. So kind of similar to what happens with the surface antigen and then developing surface antibody as it clears. You have that same concept here where you initially start for those who are infected with being E antigen positive, and then over time losing your E antigen and developing E antibody. And this is typically associated with lower viral load and can be associated with mutations. Then finally, the third serological test, so it doesn't mean the only test you'd be checking, but the serology test specific to hepatitis B is the hepatitis B DNA PCR or viral load. And this is often what we refer to as your Hep B viral load. It's a DNA PCR test, and it tells us how much active viral replication is happening in somebody who has active infection or is surface antigen positive. So these tests kind of all put together, in addition to other assessments or tests, are how we determine in those who have active infection what's the most effective way based on the data that we have available to manage these patients. And not all patients will be recommended for treatment immediately. And the way we make this determination of who is recommended for treatment now and who can wait and how patients should be monitored are based on these serological tests with additional tests, which we're going to talk about in the upcoming talks. So let's talk a little bit about how we put together the screening test results. Okay, so your first step in terms of serological workup or screening for Hep B, and how do you interpret the findings or results of those tests in terms of what's going on with the patient. So we're going to spend this slide and the next slide kind of talking about the different kind of permutations of how to interpret, whether or not these tests individually are positive and negative and putting them together. So in somebody who's surface antigen negative, remember surface antigen is the test that tells us if you have active infection. So that's negative here. So they don't have active infection. And if their core antibody is also negative and their surface antibody test is negative, this is an indication that the person has never been either infected with Hep B and or immunized to Hep B. So that really puts them in a category of people that are susceptible to this infection. So this is a category of persons that will often think about offering and counseling, recommending for them to be Hep B vaccinated. Now remember, Hep B vaccines, we have highly effective vaccinations for hepatitis B. Starting in 1991 in the United States, we implemented more universal implementation of a Hep B vaccine at birth, which has really led to a steady downward rate of Hep B infection in persons born in the United States since 1991. Now, we've certainly seen in the last 4 to 5 years a bit of an uptick actually in the number of cases of Hep B. And those are typically in persons who were born prior to 1991. And unfortunately, we're seeing it in large part due to unintended consequences, secondary consequences of the opioid epidemic and drug use. So remember, if all 3 of these screening tests are negative, this is somebody who's susceptible to, for whom you can actually offer a highly effective Hep B vaccine. The next scenario is somebody, again, who's hepatitis B surface antigen negative. So that means they don't have active infection. But when you test their core antibody and surface antibody, both of those tests come back positive. And remember, surface antibody by itself doesn't tell us, it certainly tells us somebody's immune, but it doesn't tell us whether or not they're immune because they were infected and cleared the virus versus whether or not they got vaccinated. And that's where in this scenario of being surface antigen negative and surface antibody positive, the core antibody can be very helpful. And if the core antibody is positive, that it indicates immunity due to prior Hep B infection, okay? And so that's how you distinguish in those persons who are Hep B surface antibody positive, who's immune from vaccine versus prior Hep B infection or natural infection. So that brings us kind of the third scenario here, where again, somebody is surface antigen negative, so they don't have active infection. Their surface antibody is positive, but their core antibody here is negative. So you see how these two are different. So again, the surface antibody being positive denotes immunity. And now knowing the core antibody status, you know that this is due to prior Hep B vaccination. Now, what I'll kind of also mention before we get to the next slide and the other interpretations of these tests, is that Hep B is notorious for not really following a lot of the rules. And so, these, generally are tried, tested, and true. And sometimes we see funny things happen, and there are a role for repeating some of these serologies, which we'll talk about in some of our case discussions. All right, so that brings us to kind of the next set of test results and how to interpret them. So I just went through kind of all of the many of the surface antigen negative scenarios. So now we want to turn in the next two to those people who are surface antigen positive. So that by definition means that this person has active Hep B infection. And here you have the result of the Hep B core antibody and surface antibody. So the core antibody is positive here, and the IgM core antibody is also positive. So again, you'd only be checking the IgM core antibody, because remember the standard core antibody test is an IgG total antibody. It's not an IgM. IgM, remember, for viruses is usually something that's positive in the acute phase of infection or recent. So this will be positive usually within the first couple of weeks of infection. And if that does come back positive, that is a marker for acute infection or very recent infection. So that can certainly be checked in the right clinical scenario. We don't typically recommend it in kind of how we screen people generally for Hep B outside of anybody who's got reason to think that they've been recently infected or exposed. The next category includes, again, somebody who's Hep B surface positive, antigen positive, so they have active infection. And here what you see is that their core antibody is positive, and you check their IgM and their surface antibody, and both of those tests are negative. And this is most commonly what you'll see in somebody who's chronically infected. So you can also be chronically infected with just the surface antigen positive. Again, having surface antigen for 6 months or greater puts you into that chronically infected by definition category. And you'll often see in these patients that their core antibody is also positive, but it doesn't have to be 100% of the time. And then finally, I think the screening test scenario that raises the most confusion for people, and I'm going to try to simplify this as much as possible, is somebody who's surface antigen negative, so they don't have active infection. Their surface antibodies also negative, so that may raise questions about whether or not they are immune. But you check their core antibody, and that is positive. Now, 9 times out of 10, and I think this is really the thing to remember in this scenario, 9 times out of 10, this is going to be a scenario that's consistent with resolved infection. So somebody who has been infected, somebody who has immunity, because they are still core antibody positive, we're going to talk about this in the last of the 5-part series, they're still at risk for reactivation of Hep B in the setting of immunosuppression. And so it's important to understand that, again, in the vast majority of cases, when you see this scenario, it's because they've been previously infected, they resolve the infection, and by definition, they're no longer infected because their surface antigen is negative, but they just, for whatever reason, never went on to develop the surface antibody test, the most common test we associate with immunity. These patients are considered immune. These are not patients that we try to vaccinate to develop surface antibody. And so it's really important, again, 9 times out of 10, it's they've been previously infected. Now, there are 3 other possible interpretations of this scenario. One is that this could be a false positive, and this also could indicate a low-level chronic infection, or what we call occult infection. So somebody who's not following kind of the standard definitions, and I kind of started out by saying Hep B doesn't always follow every one of the rules when we're talking about the serology, but most of the time you will find somebody fitting into one of these interpretations based on the serologies. And the only way to detect this is either by checking the Hep B DNA and or staining it for it on a liver biopsy. So this is exceedingly rare to have occult infection or low-level chronic infection. And so, in this scenario, checking some additional tests, including your Hep B DNA level, it can be a good appropriate next step. The final potential interpretation of this test is resolving acute infection. So somebody who's in between, you know, they've lost surface antigen because their body's clearing the infection and they haven't quite had enough time to develop surface antibody. And, you know, Ashley, I think one of the things that we can do at the end of this talk, in one of our earlier boot camps, someone had shared a really nice short YouTube video that had been put together by one of the public health agencies. I don't think it was the CDC, but it was somebody else, and it was really helpful because it talks about the time frame for when these different serological tests are typically going to be reactive. So
Okay.
share that with everybody at the end of the session. It's something I do a lot of learning from you guys, and you guys point me to resources and us to resources that we think are really good. So I'm happy to share that to give people a little bit better sense of how quickly are tests positive, when to look for this, time frames, because that's often a question too. But again, in this last scenario, I think the thing for you to remember, 9 times out of 10 cases, it's going to be that this is somebody who was previously infected and is no longer infected, but just never went on to develop that surface antibody marker, okay? And if you are worried that this is a false positive, low-level chronic infection, resolving acute infection, you can repeat these tests after a period of time, and or check some of the other tests you would check in somebody that we talked about in terms of a step 2 in somebody who's surface antigen positive. So you could check your e-antigen, e-antibody status, and either one of those are positive, you know that that's somebody who's been previously infected. That person technically should be antibody positive. You can check the Hep B DNA to make sure they don't have low-level chronic infection. And then you can repeat serologies to see if they develop surface antibody over time to see if it fits with resolving acute infection. So there are, by repeating or checking some of these additional tests in at least, you know, a 6-month time frame, that can give you a better confidence about which scenario you're dealing with. If everything stays the same, you're again still left with this person being then in the resolved infection category. All right, so in somebody who you identify as being surface antigen positive, we talked a little bit about checking e-antigen, e-antibody, and your Hep B DNA level. So what other assessments are we trying to do in these patients to get a better handle or understanding of where they are with their Hep B infection and liver disease? So again, your markers for Hep B infection that you want to make sure that were checked, obviously your surface antigen, which should have been your screening first check, followed by also your e-antigen and e-antibody and your Hep B DNA. So these are the serology markers you want to make sure are checked for anybody who's surface antigen positive. And then second, you also want to check additional metrics to try to get a sense of what's the status of their liver disease. So the ALT, which is usually in your hepatic panel, your comprehensive metabolic panel, can sometimes even just be individually checked. Your serum ALT level, also referred to sometimes as your hepatic enzyme or your liver enzyme test, is a test that's important to know the status because it influences who you recommend for treatment now versus weight. And we're going to talk about how this fits in into the treatment and recommendation monitoring paradigms. And then finally, what you also want to do in every patient with hepatitis B is do some type of assessment for the degree of fibrosis. Now, fibrosis is typically scored on a scale of 0 to 4. Before we had non-invasive ways to evaluate fibrosis, the only way we had to do this was through a liver biopsy. Now, you can imagine liver biopsy is an invasive test. It raises a lot of concerns, worry, you know, from the patient standpoint, from the provider standpoint. It's typically a safe test with very rare complications, but it is invasive. And so over time, what we have developed kind of from the liver literature largely are non-invasive ways to evaluate fibrosis. So some of these measures include biomarkers. So sometimes you can check, you know, FibroSure, FibroTest, lab tests using Quest or LabCorp or BioReference Labs. We also have non-invasive technology using shear waves or elastography to measure stiffness in the liver. And we know that stiffness correlates very well with fibrosis now. So you may have heard of tests like the FibroScan or MR elastographies, which is a special type of MRI test. And this can be helpful to try to measure how much stiffness in the liver. And then, as I mentioned, liver biopsy is still done in selected cases, but we do it a lot less frequently now that we have these non-invasive ways. And the reason why fibrosis, the understanding of where you are with fibrosis in a given patient with Hep B is that if somebody is showing progressive fibrosis, those patients are at higher risk to develop end-stage liver disease, cirrhosis, and or liver cancer. And so in anybody who's on that 0 to 4 scale, with 0 being no fibrosis and 4 being cirrhosis, anybody who's got really stage 2 or higher amount of scarring that's developed as a result of hepatitis B is typically shifting into a category that's going to lean you to recommend for Hep B treatment. And again, we're going to go into more details around how you put all of these test results and fibrosis assessment together to come up with your management plan, including treatment for patients with hepatitis B in an upcoming talk. That's going to be in the next 2 sessions. So I also wanted to, in this talk, mention what we refer to as the clinical phases of hepatitis B. And again, kind of to go back, to not only are sometimes the screening tests a little tough to decipher and put together, I think the other barrier for adoption from a provider standpoint in terms of integrating more Hep B screening and even treatment into practices has to do with some of the terminology that we use and how this terminology describes actually what's going on or doesn't describe very well really in a given patient. But we think of Hep B over time as really having these different phases. And in the first 10 to 20 years, as I mentioned, patients will typically be E antigen positive. So remember, the test after you find out somebody's surface antigen positive, you're going to check their E antigen, your E antibody, your Hep B DNA, and then your ALT test, like I just mentioned on the last slide. And these tests together can kind of give us clues as to which phase a person might be in. And that's important because as you go over time, you are more likely to develop more damage in the liver. So in an early phase of infection, people are typically E antigen positive. They will have a very high DNA level, okay? And the DNA level, like I said, we don't always follow any specific set pattern, so this can fluctuate over time. But when you're E antigen positive, typically in that early phase, you'll have a very high DNA level, and your ALT will typically be normal to minimally elevated. We refer to this phase as immune tolerant. And I think, again, this phase is somewhat, this description for this phase is somewhat problematic because it doesn't really tell me a lot about should I be worried or should I not be worried? But, hopefully this word tolerance is conveying that they're really in a phase that's early. If we were to biopsy a person in this phase, they typically will have no to minimal fibrosis. And so these are not people that are typically recommended for treatment very aggressively. Now, when we say high Hep B DNA level, we're typically referring to something over 1 million IUs per ml. The labs can report your DNA PCR level in either IUs per ml or copies per ml, and it's just a conversion factor of around 1 to 5.4. So greater than 1 million IUs per ml would go with a very high Hep B DNA viral load. And again, typically happens in your first 10 to 20 years of having this infection. So we have a lot of young patients, particularly young Asian and African-born patients that you might see who, again, if they're young in terms of age and you suspect they may have acquired this in early childhood or as a newborn or at the time of birth, oftentimes they'll be in this immune tolerant phase with a really high Hep B DNA, but doesn't really mean there's a lot of fibrosis in the liver. Then over time, what happens is you can still have your E antigen that's positive, but then over time, your Hep B DNA typically comes down. And as it comes down, your ALT will go up and your E antigen titers come down over time and you lose E antigen and you develop E antibody. And during this phase, we think about it as immune clearance. So if you were actually following this patient every 3 to 6 or 12 months and checking these numbers, you might all of a sudden start to see a shift where the DNA is coming down below 1 million. Your normal ALT is then going up over time. And what you want to do is keep your eye over time with what happens to the E antigen test, whether or not you lose it and or whether or not you develop E antibody. And again, this is what we used to refer to as immune clearance. So this E antigen positive patient, they may have a little bit more hepatitis activity if you were to biopsy them. And then this is then followed typically by what we used to call inactive carrier state, which I think is the most unhelpful term we could ever give somebody, because as you're progressing in this timeline, you typically are developing more fibrosis. And even in this inactive carrier state where you're typically E antibody positive and your Hep B DNA level might be low and your ALT level might be minimally elevated to low, you can still have some fibrosis there that's progressing over time. And so when you go from inactive carrier to reactivation and developing more progressive fibrosis can be difficult to tease out. But again, you might see some fluctuations or changes in your DNA and your ALT level that could give you clues. Now, these phases are really not used, we can't hang our hat on the test values always fitting into a box consistent with one of these phases because of these dotted lines. So this is just to more give you a general sense of what happens in a person who's infected with Hep B over time. So someone just wrote in, it's my impression that all Hep B patients need HCC screening. So Katie, this is a really, really important question. And so there are some categories of people when they hit a certain age, we recommend liver cancer screening independent of fibrosis. You are correct that Hep B is directly oncogenic and it's very different than other causes of liver disease, and that the risk of cancer is not related to developing cirrhosis or a lot of scarring. Now, that being said, we don't start liver cancer screening on newborns and infants who might acquire this infection as a newborn, because we know that having the virus for time is what increases your risk. And so in an upcoming talk in one of these, in this series, we're going to talk about when and in whom you start liver cancer screening and what age. And some of the take-homes I'll just kind of give you as a teaser is that some foreign-born groups, particularly East Asian and East Asian men and Africans, African men or Black men are recommended to start liver cancer screening earlier, independent of their level of fibrosis. Okay, but more on that to come. It's a really important question, and we're going to cover that. All right, so over time, some of the societies, including the European Society, have shifted some of the terminology to try to reflect something that might more accurately capture or depict what's going on, depending on what the status of these lab tests are. So this is essentially the same slide that I just showed you. Again, in an earlier time point of having this infection, you'll be E antigen positive, and over time, you'll lose that and develop E antibody. Your Hep B DNA viral load might be very elevated in these early E antigen kind of years, and your ALT typically is normal. Again, we used to and still in some societies call this as immune tolerant, but this really means that there's normal or minimal hepatitis going on and usually no fibrosis. So these are typically not patients that we're jumping the gun to recommend treatment on. Remember, for those patients who are born with this, and this is a lifelong illness, we need to be really kind of thoughtful and mindful about what we think the benefits of treatment are, because the currently available treatments right now are lifelong. We will talk a little bit about a new wave of treatments that are being developed right now to try to get at this issue of cure. But the FDA-approved treatments currently are typically lifelong treatments for most patients, and therefore we need parameters under which and when and which circumstances to start treatment. So immune tolerant is not usually somebody we are rushing to start treatment on. And then after years of having this infection, again, your DNA level will come down. You might start to lose E antigen, develop E antibody, and your ALT go up. And that is usually consistent with immune clearance. We now usually refer to this as being in a chronic hepatitis phase. And then over time, you can go on to have your ALT come down, your DNA be low and you develop E antibody, what we used to call inactive carrier, now normal or inactive hepatitis. And then over time, what you're at risk for is developing progressive fibrosis. And independent of fibrosis, you can be at risk of liver cancer, as Katie just pointed out. All right, so we wanted to really go through a discussion of tests and lab values. So we talked about our case. So just to recap, our 28-year-old woman who was born in the United States, whose parents immigrated from Taiwan. So we talked a little bit about the screening tests. So we would check, the 3 tests we would check would include your surface antigen, your surface antibody, and typically your core antibody test as well. So now let's go back. Because I don't think we had and I'm gonna open it up. So if anybody has any cases they wanted to present today, here and now, that'd be great, but I don't think we had any cases submitted in advance, correct, Ashley?
We don't have any cases submitted in advance. So
okay, so let's just take what time we have left to kind of address questions you might have. And then I just wanna start by talking about that initial case. So let's say we did the screening on that person and they come back in this category. So their surface antigen test is positive, their core antibody test is positive, and their surface antibody test is negative. So that, means that they're chronically infected. What additional testing, based on what we covered today, would you recommend for this patient at that point? So I'm going to open it up for people to use the chat function and or just chime in with what they think they would recommend. So somebody who's chronically infected, what's the next test? Okay, Brianna, great, thank you for writing in. So yes, you want to check your E antigen test and your DNA test. And you also probably want to check your E antibody test, right? So I would add that in addition to the E antigen and DNA test. So your viral load, your E antigen, and your Hep B E antibody, okay? And that's very important. What other 2 things are you going to do in addition to checking those tests, in terms of assessing how much liver disease they might have? What additional things might you consider? LFTs, yes, thanks, Brianna. So your LFTs, liver function tests, which to be honest is like not a very good way to describe what we think of as liver function tests, but your hepatic panel and comprehensive metabolic panel to get at your ALT. And then yes, Brianna, you want to do your fibrosis assessment, and you want to consider in the right people whether or not they meet category of risk for liver cancer screening. So you may check at least an ultrasound at baseline as well. Okay, Susan, you also mentioned, yes, elastography. I'd love to hear from you guys. Have you heard of elastography? What elastography tests? Is it in the form of FibroScan or MRE that you have available? Do people have this test available to them where they are, they're providing care?
This is Katie. In Philadelphia, we have to refer. We have 2, and we have to get a prior auth through the patient's insurance and then send them. And we don't have a lot of success unless someone's a little bit higher functioning, but it takes a little, we can get it done if we have to, but it's not for everybody.
So that's really important. So, it is a newer test that was finally approved by the FDA a few years ago. So it was assigned a CPT code. And the prior authorization can be a barrier to people who don't have it on site. And so, Katie, are there other tests sometimes you think about if you can't get it authorized, or other ways you try to do a fibrosis assessment?
We just use the serum F scores.
Okay. So usually like through a fibro test, or
I think is the brand.
Yeah.
Or liver.
So one of those like tests on your lab slip to check fibrosis assessment. Yeah. Brianna mentioned ultrasound, so I would agree with that. Checking a baseline ultrasound to kind of just know what structurally is going on with the liver is important as just baseline, and that also can help establish something to compare it to. If somebody does develop symptoms and needs repeat testing, or then goes on to have engage in liver cancer screening, which again, we're going to save that for more detail in an upcoming talk, but there are categories of people independent of fibrosis. So this is a really key concept here, guys. This is very different than like Hep C and risk of liver cancer, or alcohol liver disease and cancer. Those happen by way of developing cirrhosis, and cirrhosis is really the big risk factor. So really with Hep B, you can develop liver cancer or hepatocellular carcinoma independent of having cirrhosis. Yep,
Sorry.
go ahead.
The other thing that I've done for uninsured patients is calculate the API, because if you don't, that can be an estimate if they have cirrhosis or not.
Yeah, so have people heard about the OPRI test? Let me actually see if I can stop sharing and go to some of these web-based resources. Have folks heard about the OPRI test? Yes, okay, Minowata said, yes, I've heard about the OPRI test. So let me just do one thing. So the OPRI test, the CDC actually worked with University of Washington to develop some web-based materials. And let me see if I can show this. I think some of these non-invasive tests were used more widely, certainly for hepatitis C infection, but have been translated to other diseases, including hepatitis B over time. So let me see if I can share this with you. So the CDC worked with, can folks see my screen?
Yes.
Okay. So I think, Katie, you just mentioned the OPRI calculator, right? So, and what's nice about these calculators is that some of these are just generalized calculators that can be used for liver disease. So APRI is the AST to platelet ratio index. So if you look at the AST level of a patient and you put the upper limit of normal here, which could be 45, it can be 54, it can be any number. So it's really important to look at the assay reference range on the test you're ordering from, if it's your in-house lab or outside, LabCorp or Quest Lab, and then the patient's platelet counts. And then what it does is it gives you a nice little interpretation. So if the OPRI score is greater than 1.0, that has sensitivity pretty high, 76%, and specificity 72%, predicting cirrhosis or more advanced liver disease. So some people define this as clearly stage 4 or 3/4. And they also concluded that the OPRI score greater than 0.7 still had very high sensitivity, 77%, and specificity for predicting significant hepatic fibrosis, which is typically, again, your stage 3 or under 4. And if that OPRI score is less than 0.5, it has a very high negative predictive value to really rule out cirrhosis. And so, again, this is something that doesn't require you sending them for any additional testing. Your AST is going to be checked when you check their liver enzyme test, and your platelet count is typically going to be checked when you do a CBC. The other thing I'll mention is this test called the FIB4, which again was first validated for patients with Hep C, but has now been studied for patients with Hep B. And typically a cutoff certainly greater than or equal to 3.25 using the patient's age, their AST level, their platelet count, and their ALT. Again, not sending them for any other additional imaging, but things you can just do based on their age and their blood test. If it's greater than or equal to 3.25, that's associated with more advanced fibrosis, which means stage 3 or 4 fibrosis based on biopsy. And we do know that patients with a FIB4 score greater than 1.4 have increased mortality generally in the population. So if this test is certainly less than 1.4, that's very helpful to say that this person usually does not have very significant fibrosis. And then values in between that are very difficult to interpret. So it's really helpful, really, these tests with trying to delineate who might have very advanced liver disease and not very advanced liver and very minimal liver disease, but doesn't tell us who might be stage 1 or 2 on that scoring system. So some limitations there, but good to know about the resources. Okay, so would love to open it up to any additional questions folks might have. So I'm going to stop sharing there. Yes, and Julie made a comment here for the whole group to see some places have ultrasound with elastography reading. That is correct. So some radiology facilities are kind of using shear wave technology that are not quite fiber scans. They combine really an ultrasound reading with shear wave testing. more formally. Now, a FibroScan by definition does do a limited ultrasound, but it's in such a small segment of the liver that it's not really considered, ultrasound combined with elastography. It's really considered elastography. But basically the whole idea with elastography is that you're using sound waves or these shear waves to try to measure stiffness. So I think that answered that question. Do folks have other questions about tests you might do for this patient? I think we covered all of them. So somebody who's surface antigen positive, just to recap, you want to check their e antigen, e antibody, DNA, your ALT at a minimum, but you may want to check the AST too so that you can check your OPRI score if you wanted to non-invasively assess their fibrosis. And then we're going to talk about liver cancer screening, but getting a baseline ultrasound is typically helpful and recommended as well. All right. Any questions about any of that, or questions about anything that we covered today with respect to serology? So Doug's raised his hand. Dr. Douglas.
Can you hear me?
Yes, you are unmuted.
Yes. Beside the case that you presented, by the way, the talk was great. If the person is co-infected with HIV or even Hep C, would that change your management in terms of interpreting the tests, vaccinations, screening, be more vigilant for HCC?
So that is an excellent question. So the question, Dr. Douglas, is specifically if you have somebody who is HIV co-infected, correct?
Yes, because pretty much most of my Hep B, I usually see them in this scenario where they're co-infected with either Hep C or HIV.
Yeah, so there are not formal recommendations to be screening them for liver cancer any earlier. So that I'll start by saying that. Now, we do know patients who have HIV infection can develop more accelerated fibrosis in a shorter period of time. There just hasn't been really great data to show the benefits of doing liver cancer surveillance in this patient population as of yet.
Okay.
Now, the one thing I will say that's a little different, it is recommended that you screen, I think there's a little bit of feedback on somebody's line. So just mute yourself if you're having a lot of background noise, if you could, that'd be helpful. But you would also screen them for Delta infection. And I'm going to talk about Delta infection in the fifth talk. We're on number 2 out of 5 talks here. And so we'll talk about who's at higher risk for Delta infection. But Delta is basically a viral infection. It's a hepatitis infection that requires Hep B infection to be present. So there are different ways it can be transmitted. It can be transmitted to somebody who already has Hep B infection or at the same time with Hep B infection. And the scenario in which you think that is present can really portend worse outcomes with liver disease, and you can have people develop cirrhosis in half the amount of time than somebody who's just got Hep B infection. But Delta infection is recommended to be screened with at least an antibody test to start with in anybody who's HIV infected with Hep B. Now, in terms of vaccinations, everybody with hepatitis B is recommended to be checked for their hepatitis A status, and if they're Hep A negative, they're recommended to be vaccinated against hepatitis A. This has been, typically just a CMS core measure for patients who have liver disease in general. So by definition, having Hep B means you have liver disease, and we would check your A and B status if you were not even B positive, but had some other liver disease to look for opportunities for prevention through vaccination. The reason also to do that is that if you were to develop acute Hep A infection, on top of already having Hep B infection, you would be at higher risk for acute liver, a fulminant hepatic failure picture, acute liver failure picture in that context of developing acute Hep A. But that's not specific to having HIV infection. That's something kind of across the board we recommend. One other final thing I'll just mention is that we don't have very refined QI metrics in a lot of our liver diseases. I actually just came back from Boston yesterday, where we were having our annual liver meeting, and there's actually now going to be a working group dedicated to developing better QI metrics in all liver diseases, and we'll certainly see how this impacts what we see with Hep B. For Hep B, we do recommend screening for Hep A, and if you're negative, then to vaccinate with the Hep A vaccine to prevent somebody from getting another liver disease that's very highly effectively preventable through vaccines. Does that answer your question, Oren?
It was very concise. Thanks.
Okay, great.
And we had one more hand up, Katie.
Okay.
I had two questions, and you might not be able to cover both of them. But the first is in regards to the HIV positive patient. I know there's some literature that says that having a core antibody positive but not mounting the surface antibody response is more common in HIV positive folks. And I wanted to see if you could speak to that.
Yeah, so that is true. Any things that affect kind of your immune system have been, like, they've done kind of various studies. The other study that's also been done is just even looking at your response to like a Hep B vaccine. Okay, so not somebody who's going to even be core antibody positive, because remember, core antibody positive usually means you've been infected with Hep B at some point. But yes, you typically will not mount as robust of a response if you have another condition that's impacting your immune system. And there have been studies that show that well-controlled HIV with undetectable viral loads and good CD4 counts are associated with higher rates of surface antibody development. But then even just being kind of at the extremes of age, so higher age is associated with less robust surface antibody response, either due to infection and or vaccine, and other comorbidities have also been shown to do this. So I think where this is most challenging is where we're trying to really show when we vaccinated somebody that you've had a good response. So it's not really the core antibody person that I think you're referring to, but even in terms of developing a robust immune response where the surface antibodies positive to our highly effective vaccines can be tough. And in those scenarios, where you might start out on vaccinating them on a standard schedule, but then you might convert them and try to revaccinate them to show that surface antibody response by an accelerated vaccine schedule. And there are a number of those that are, if you Google them, the CDC has a couple of them posted to their website, among others. So does that answer the first part of your question, Katie?
Yes, it does. Thanks so much. And the second part was just to clarify that the elastography that's done during a standard ultrasound is not as accurate as elastography that's done as part of the FibroScan.
Sorry, can you, I think I don't know if you cut out for a little bit there. Can you just say it one more time?
Just comparing the real-time elastography that's done during an ultrasound versus the transient elastography that's done as part of a FibroScan. And it's my impression that you can't rely on the real-time that's done as a part of an ultrasound.
You know, I think we don't have as much data with real-time ultrasound. There may be some comparison data that, you know, quite honestly, I may not be the most up-to-date on at the moment. I do know that ultrasound with elastography is not as, certainly clinically, as widely available at our sites. And so a lot of sites have invested, and one of the drawbacks of the FibroScan is that it's a very expensive instrument, and so it's hard to get that integrated into a lot of practice settings. And then, as you mentioned, there are a lot of the barriers with getting prior authorization since the test was, which was done. Now, what I also have found, just Katie, between you and I, is that in resource, limited settings where it's difficult to get the FibroScan, we've been able to develop relationships with places that don't have availability of FibroScan, and sometimes even setting up some type of system to offer it discounted or free for patients who might meet certain characteristics, like uninsured populations and some of the others. So the reality is the reimbursement's not great actually for FibroScan at the moment. I think it might be getting better over time, but you might sometimes be able to work out a relationship with some of those referral centers to see if you can get discounted or sometimes even free FibroScans if they're willing to do it.
Okay, great. Thank you.
Yeah.
All right. Well, if there are no other questions, I want to thank you all so much for attending today, and hopefully we'll see you next week in our part 2 for serology. And if anyone wants to volunteer a patient case, please let us know. We'll send out the case form with our email as well.
Great.
All right. Thank you everyone for joining us. Have a good day. Thank you, Ponni.
Bye. Have a great
Bye-bye.
week.